So in classical Hodgkin lymphoma, one of the big points of controversy now is if you had everything available, and not every region does, and certainly in England we don't, but if we had every sort of regimen available, which one would you use in advanced stage patients? And the big two are BrECADD, so that's an evolution of escalated BCOP to involve Brentuximab, switching procarbs into dacarbazine, prednisolone to dexamethasone, fiddling a little bit with the other chemotherapy doses. That's BrECADD, and that's quite an intensive approach versus Nivolumab AVD. So it takes ABVD and simply replaces the bleomycin with Nivolumab. That's the SWOG 1826 study that showed a benefit over BVAVD for that regimen. Both are excellent regimens, there's no doubt about it, but the debate we were having is, in particularly a young patient, would you use BrECADD or Nivo-AVD? I was arguing for BrECADD. I do believe quite passionately in BrECADD there, partly because the 5-year progression-free survival in the 18 to 60-year-olds from the HD21 study is 94%. I mean, you can't get much higher than that, 94% excellent. Nivo-AVD a little bit lower at the 3-year mark, that's 91%. Of course, the trials aren't identical, but still an excellent result. But the real advantage, I think, of BrECADD is the duration of treatment. So for most patients, they only need 4 cycles, and that's over in 3 months. So I was trying to illustrate that, it's June now, so if we started a young patient, we'd be finished by August and they may be able to go off to university, because they're often young patients, end of September. Whereas if they were on Nivo-AVD, that's always 6 months of treatment, and we'd probably be just about ruining their Christmas, because it's so much longer. So that short duration of treatment enables people to get back to work, back to their studies much more quickly. So I think for the right patient, not for every patient, but that more intensive, shorter approach with excellent outcome data is the right way to go.